وإيش الانفستيجيشن بالضبط و questions to participate and discussion والmanagement prognosis. طبعا ال questions يعني أو ال information we should learn after this session إنه مثل diagnosis of this condition, definition و its classical clinical picture, what are the possible differential diagnoses ونحكي إيش ال possible sites اللي ممكن يصير فيها هاي ال condition, الانسيدنس, الريسك فاكتورز, البوسيبل etiologies وايش الانفستيجيشن اللي لازم نعملها عشان to rule out this condition وايش ممكن البوسيبل complications والمانجمنت وits prognosis. Here we go. الكيس يعني I made it. 27 years old woman married for 2 years. She is gravida 1 para 0. Her last menstrual period was 7 weeks ago. Her blood group is O positive. Presented to the emergency department with vaginal spotting and right lower abdominal pain for 2 days duration. Upon further questioning, she said that she noticed a dark red bleeding 2 days ago and wasn't heavy. The abdominal pain started at the right side, which was cramping in nature and localized. She had no fever or change in appetite, nausea, or vomiting. She said that her bowel and urinary habits were normal. She had no previous gynecological history or previous medical illnesses, previous surgeries. She had no drug history. تفضل دكتور يعني if you want to comment before we proceed.
No, go ahead. Still too early to interject.
Yes. طبعا after we took the history from this patient, we took the vital signs and there were like this. Her blood pressure was normal, 128 على 78. الهارت rate was 82. Temperature was 37.1 Celsius. طبعا هاي كان موجود. طبعا then we went to examine her. The patient looked uncomfortable. The abdominal exam showed right lower abdominal tenderness with no rebound tenderness or guarding. ما كان في abdominal masses upon palpation. كمان عملنا vaginal exam which showed closed cervix with scant blood in the vaginal vault.
So that's a speculum exam.
Yes.
So in real life, you have to specify what type of pelvic examination you have done. So let me just slightly change the last issue. So this lady, she's normotensive, normocardic, afebrile. She has right lower quadrant tenderness, not rebound, with no guarding or rigidity, and no masses felt. On speculum exam, the cervix was closed with scant blood in the vaginal vault. We should ideally also do what type of exam also? Any suggestions in regards to additional examinations we might do?
Yes.
Just if you have an answer, please raise your hand for us to listen to you. الصوت عم بقطع، صوتك عم بقطع. في حدا كان بده يحكي بالصوت بقطع. ما سمعت. So we should do a bimanual exam. Let me just answer it. We should do a bimanual exam. What would bimanual exam show us if there is actually an ectopic pregnancy? What might it show us?
يس دكتور، بهاي الكيس يعني ما عملوا باي مانوال.
Let's presume they did a bimanual exam, and this lady does indeed have an ectopic pregnancy. What might a bimanual exam reveal to us? Yeah, Yafa?
Cervical excitation.
Cervical excitation might occur. Is there anything else that might be revealed during bimanual exam?
ممكن دكتور tenderness بالfornices.
I had a cervical motion tenderness. Cervical motion tenderness is whenever you put your dominant hand in the posterior vaginal fornix and you try to move the uterus, you'll elicit some tenderness. It's usually localized to the right or the left side, and we call it cervical motion tenderness. It's not specific to ectopic. It will just give us a hint that there is some issue irritating the parametry or the adnexia. You might also feel a mass in the adnexia. So these both will be revealed by my manual exam. Abdominal exam, usually you need a large mass to be felt abdominally, but by manual exam will reveal smaller masses. You can proceed. Continue, doctor.
Thank you. يمكن Philippe wants to talk about this الحين, investigation or imaging.
So بعد هيك عملنا احنا ultrasound, transvaginal ultrasound, وما لقينا انه في intrauterine gestational sac زي ما بنشوف عادة بالnormal pregnancy. بس لقينا في right adnexal mass with fetal heart. هنا إذا قربنا أو ما بعرف إذا الأروز عندكم واضحين، بس هون we can see اليوك sac مع الفيتال pole، وعادة هاي الفيتال pole تبين after 6 weeks of gestation، وهنا بنشوف عنا gestational sac on the right. السلايدز
On the left of
وهاي
the
اليوترس عنا. تمام. دكتور بدك تعلق عليها شيء؟
Currently no. بعدين راح فرجيكم صور ثانية، مش مشكلة.
تروح اللي بعديها حسن.
رحت تحرك عن
ثواني أنا عندي مش تحرك، ثواني. تمام، بعديها عملنا investigations. البيتا HCG was done والهاي results 7400. السي بي سي كان الهيموغلوبين 12، platelets 223,000 أو this finding اللي هو normal platelet count. other things were also normal. نروح اللي بعديها. فعندنا هون البيتا HCG يعني we can't يعني من اوكي it's يعني النمبر هذا عادة بفيدنا لما نعمل following احنا للترندز، كيف البيتا HCG كيف راح يزيد، هل عندنا normal pattern او abnormal pattern. هاي راح تبين معنا بالsubsequent beta HCGs that we might do. على اللي بعده حسن.
Yes.
تمام. What is the most likely diagnosis?
Okay, let me change the first question from what's the most likely diagnosis to what's your differential diagnosis in this case. So we have a lady at 7 weeks of amenorrhea, and she has some vaginal bleeding and abdominal pain. Her abdomen, she's vitally stable. Her abdomen is soft lax with left iliac fossa tenderness, if I remember correctly, and some blood in the vagina. Her beta HCG is 7400. What should our differential diagnosis be? Again, please raise your hand before talking. حسن تفضل.
حسان دكتور.
حسان عفوا.
most probably أول شيء بنفكر بإكتوبيك pregnancy. ممكن نفكر BID pelvic inflammatory disease.
Okay. فيش تاني؟
ممكن
PID is not part of our differential diagnosis, by the way. محمد أسامة إذا كان صح أسامة.
Yes دكتور ممكن يكون miscarriage.
Could be a miscarriage, correct. What else could it be?
ما عندي فكرة.
Okay, حسان جميل.
حسن دكتور حسن.
حسن هو كلكم كاتبين دبل اس. اوكي حسن اسف.
لا مش مهم. دكتور ممكن تكون UTI او kidney stone.
Now we're not talking just about abdominal pain. Let's just reiterate. We have a presentation that is called a first trimester vaginal bleeding. So whenever a lady has any vaginal bleeding, she's pregnant and she's in the first 13 weeks of pregnancy. We have a certain set of differential diagnoses that we should try to either confirm or rule out. One of them, and the most critical one to diagnose initially, is ectopic pregnancy. I agree. Then we talked about miscarriage. There are further two differential diagnoses we should discuss, and UTI is not one of them, nor is PID. Yafa?
corpus luteum cyst ممكن.
It's unlikely to cause abdominal pain unless it's complicated, and this is very rare, and it does not cause vaginal bleeding.
Okay.
Hamza?
Doctor, fibroids.
Fibroids do not cause vaginal bleeding in pregnancy unless they cause the miscarriage, and then the differential diagnosis will be a miscarriage. Ali?
Doctor, I was thinking about smaller pregnancies and spontaneous abortions, maybe.
Okay, and you should think about molar pregnancy because that's one of our differential diagnoses. In regards to abortions, please try to refrain from using the term abortion. Okay, we try not to use the term abortion and use the term miscarriage rather. Do you guys know why do we try to use the term miscarriage rather than abortion? Okay, because when you say abortion, it entails that this is an intentional etiology. Okay, and it's psychologically distressing to the mother, and it might have legal implications later on. So most new textbooks, you will not see the term abortion written, you'll see miscarriages. Philip?
ممكن نفكر ب tube ovarian abscesses.
I wouldn't think about tube ovarian abscesses, just like I wouldn't think about PID. They rarely do occur with pregnancy. If they're already there, no pregnancy will occur. هلا؟
دكتور ممكن تكون كوريكو كارسينوما.
تاني مرة؟ What type of carcinoma?
كوريكو كارسينوما.
كوريو كارسينوما، ما هو جزء من الجي تي دي والمولر بريجنسي اللي حكى عنها الدكتور. لين؟
ممكن ovarian torsion.
You all guys are answering causes of abdominal pain. Remember, this is not isolated abdominal pain. This is abdominal pain with concurrent vaginal bleeding. So torsion will not be a correct answer. Wala?
Gestational trophoblastic disease.
We already received that answer previously, as in molar pregnancy and choriocarcinoma, which are both correct. They're just different names for the same pathology. ولا؟
نعم.
لا خلص نزلت ايدي مش مشكلة. فهد؟
ممكن implantation bleeding as a normal يعني physiological bleeding in the first trimester حسب الفوليوم طبعا.
Implantation bleeding does happen sometimes, but it does not happen at 7 weeks. So it's not part of our differential diagnosis. Implantation bleeding by name, it's during implantation. And implantation happens around 5 to 6 days after ovulation, so that she might present with it just before she is actually amenorrheic. So it's not a part of our differential diagnosis. Nadine?
دكتور ممكن pre-eclampsia أو abruption.
Both are absolutely wrong, because by definition both will occur after viability. at least after 20 weeks. So by definition, they do not occur in the first trimester. Our last differential diagnosis looks like slightly harder for you guys to reach. It's actually local causes. By local causes, we mean it's bleeding from the vagina itself or the cervix. So let's say a lady has cervical ectropion, she has a cervical polyp, she has vaginal polyp, she has a vaginal laceration. These all will cause bleeding per vagina, and we call them local causes. Okay, but our top differential diagnosis in this case is indeed ectopic pregnancy. Okay, let's return to your questions, Hassan.
حسان ولا حسن دكتور؟
حسن، آسف أنا لأنكم كاتبين أسامي غلط، أنا سيء بالأسامي فآسف. دبل اس
حسن زواهري.
سوري كنت مسكر المايك هلا يعني المفروض طلعت لي سلايد.
مش مشكلة. So far we've reached our differential diagnosis. How do we go about confirming this different, or what's our top differential diagnosis? Is ectopic pregnancy. What do we mean by an ectopic pregnancy in the first place? What's the proper definition? In other words, what's the proper definition of an ectopic pregnancy? غادة؟
دكتور.
اتفضلي رافع ايدك.
دكتور ممكن هو any pregnancy when the fertilized get implanted or develop in other side of uterine cavity.
Okay, Hassan?
Yes, doctor. الامبريو implanted outside the endometrial cavity. Yes, زي ما حكت زميلتي.
Okay, so whenever an embryo is implanted anywhere but within the endometrial cavity, then we call it an ectopic pregnancy. So how many types of ectopic pregnancies are there? غادة؟
دكتور ممكن يكون uterine or extra uterine.
يعني well, by definition, if it's an ectopic, it's extrauterine, almost always extrauterine. But in general, what do you mean by extrauterine?
Extrauterine يمكن on ovarian or on the abdominal side.
Okay.
Or maybe in the.
طيب حمزة. Do you have other suggestions?
في عنا التيوبل أو الانترستيشيال.
Okay. What else?
بس هدول متذكرهم والله.
مش مشكلة.
دكتور
اوكي. تفضل حسن، كمل بلش تكمل.
يس دكتور زي ما حكى زميلي انه ممكن تكون في الفالوبيان تيوب وممكن تكون في اكثر من محل، ممكن الامبولا او الاسمس او ممكن تكون في الفمبريا.
اوكي خليني بس ثواني بدي اعمل شير انا لوايت بورد. There we go. Okay, here we go. So طبعا تحملوني أنا بالرسم سيء بس ثواني. So far, we talked about ovarian ectopics. We talked about tubal ectopics. شو كمان ممكن يكون؟
في الفمبري يا دكتور مبين
كله tubal ectopic هذا اسمه. Anywhere from the fimbria to the interstitial to the isthmus هذا كله tubal ectopic. And that's the most common type of ectopic, around 92.5% tubal. شو كمان ممكن يكون عندنا؟
بالابدومين.
اوكي بالابدومين بتحبوا تجاوبوه بس نصيحة بالامتحان ما تجاوبوه. Okay? It almost never occurs in the first place.
Doctor, are you drawing?
بس إشي بالكتب راح تلاقوه، مش راح تلاقوه برا الكتب. بعض الكتب كمان مش كل الكتب، وكتابكم مش جايب سيرة الابدومينال. شو كمان؟ تفضل.
cervix.
It could happen in the cervix, correct. شو كمان؟
في دكتور
مش سامع.
ovaries دكتور.
حكينا ovarian, yes. No, أول واحد.
دكتور they mentioned بالcorneal pregnancy يعني ممكن يصير بالcorneal.
If she has an anomalous uterus and a bicornuate uterus, yes, it can happen in a rudimentary horn, and then we call it cornual ectopic. But for that to happen, she should have a bicornuate uterus, or at least a unicornuate uterus. Okay, and an anomalous uterus. She has some sort of Müllerian agenesis in the first place, then we call it a cornual ectopic. شو كمان عندنا؟ It could happen in the
ligament دكتور.
عفوا؟
في الليجمنت ممكن تصير بالليجمنت.
No. So we have other two types, although they're rare, but we have interstitial when it happens in the portion between the uterus and the tube, and this is the one that usually kills in the first place. If a lady has a uterine scar, such as a cesarean section, it could happen at that site, and we call it a cesarean scar ectopic. So in general, 92% or most commonly is a tubal ectopic. And for you as students, whenever you'll face ectopic pregnancy in the exam, most likely 99% of the time it will be talking about tubal ectopics. It can happen at the ovary itself, and we call it an ovarian ectopic, an interstitial ectopic, a cesarean scar ectopic, and a cervical ectopic. And if it's a bicornuate or unicornuate uterus, then we'll call it, we'll call it a cornual ectopic, okay? Let's delete all of these. So these are the types of ectopic. We discussed that ectopics usually present with first trimester vaginal bleeding and an abdominal pain. Although this is not unique to ectopic pregnancies, that's how usually ectopics present, and you should always, regardless of your specialty, try to rule it out. So what should we do whenever we suspect an ectopic pregnancy in general? After doing history, after starting with history and examination.
To beta HCG test.
Okay, we'll do a beta HCG test, and what would beta HCG help? عفوا؟
بعمل مرتين 48 hours apart عشان أعمل confirmation.
Okay. My question was, you partially answered that question. Why do we need to do beta HCG? What would beta HCG help us with?
Determine if it's normal growth.
خلينا بس على raising of the hand, مش كل واحد يحكي randomly عشان أقدر أركز معاه ونعطي الكل فرصته. ففيليب أول واحد رفع إيده. Why do we need to do beta HCG?
To see إذا أصلاً في يعني to confirm the diagnosis إنه في عنا أصلاً ectopic pregnancy، وغير هيك ال levels وال patterns اللي بتغير فيها levels of beta HCG can tell us how to manage الحالة، يعني هل هو intrauterine ectopic or extrauterine ectopic.
Okay, sorry. طيب. Number one. First question. Is she pregnant in the first place? Is her amenorrhea due to pregnancy? Because most of the time in your question, you will not be sure she's pregnant. We'll just tell you she's amenorrheic. Any other suggestions in regards to why do we need beta HCG? يا حسن.
قال أنت عم تكتب على السلايدز؟
يس.
لأنه مش
مش مبين؟
لا مش مبين عندي، بس بعرفش إذا
في حدا مش مبين عنده الوايت بورد؟
أنا هم دكتور ما مبين شيء عندي.
شايفينه احنا دكتور.
عفوا.
انا شايف دكتور.
وانا شايف على الوايت بورد بس مش على السلايد.
مش على السلايد، على الوايت بورد.
على الوايت بورد يا
يس على الوايت بورد.
في حدا غير دكتور عنده مشكلة بالوايت بورد؟
دكتور أنا مش مبين عندي.
طيب خليني أطلع منها وأرجع فوت.
وايت بورد بس مش مبين
المشكلة الوايت بورد هي كبيرة، فلو
zoom out or zoom in. You can adjust it.
انتوا بتكونوا عاملين زوم ان او زوم اوت، بس مش مشكلة، خليني أعمل شغلة تانية. ثواني.
الله يا بري، والله تغيرت علينا يا بري. الله 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 الله. Excuse me, where's my house? No. Where's my house? أقول where's my house? أقول أعقل عاد. أقول أعقل.
مبين معكم هلا بلاك بورد؟
اي دكتور طلعت عندي انا.
اوكي ممتاز. فسؤالنا كان بيتا سي جي واي، حكينا 1 confirm that she's pregnant. شيء ثاني أول شيء الشيء الثاني confirm she's in the discriminatory zone. أي حدا بيعرف شو discriminatory zone؟
يس دكتور.
تفضل.
هي ال 1500 بتكون ملي international unit per milliliter.
هذا الرقم، بس شو هي؟ شو المقصود ب discriminatory zone؟ في أي حدا بيعرف؟
دكتور.
أيها؟ تفضل.
من هي
أيها بس أغلبك بعد شوي عن المايك.
نعم.
بس بعد شوي عن المايك، كان صوتك كنت تحكي بالمايك فبطلع صوت الهواء.
قديش قيمة البيتا اتش سي جي لازم تكون لحتى يكون الامبريو واضح على الالترا ساوند؟
Yes, so in other words, that's the beta HCG level at which we should visualize an intrauterine pregnancy. Okay, so if it's a transvaginal ultrasound, it's 1500. If it's a transabdominal ultrasound, it's usually 5000 units per ml, of course, per liter, sorry. That's the level of beta HCG at which an intrauterine pregnancy is visualized on ultrasound. And the last, and the one that you usually answer, reason for doing beta HCG in the first place. It's to confirm viability of pregnancy. Oh, in other words, doubling. هلا راح نحكي عن كل شيء لحال. طيب. How do ectopic pregnancies present on ultrasound? Any suggestions? بعدين راح يصير أطبع عشان الخط يطلع أوضح.
Yes, doctor.
So how do ectopic pregnancies appear on ultrasound? حسن تاني مرة.
يس دكتور، ما راح نشوف ساك بالانترايوتراين يعني لما نعمل الترانسفاجينال التراساوند.
uterus. طيب
ممكن نشوف thin endometrial line.
ما هي هاي empty uterus، هذا معناته thin endometrial line أو endometrial stripe نسميه بالعادة، معناته the uterus is empty. شو كمان؟ What's the most common presentation؟ هذا توقع؟
adnexal masses.
So it's either a complex adnexial mass or
fluids in the pouch of Douglas.
هلا fluids can't be seen in the pouch of Douglas, but fluids are very non-specific. Why could we have fluids in the pouch of Douglas? What do fluids in the pouch of Douglas represent?
Sometimes it could be in a normal pregnancy أصلاً.
Yes, usually it's normal in pregnancy, normal in most adults, regardless of whether or most females, because males do not have pouches of Douglas. So most adults will have minimal ascites anyhow. And that will be evident as collection of fluid just behind the uterus if it's female. And most pregnancies, at least 30% of pregnancies will have minimal fluid collection in the pouch of Douglas, although it could be blood, but it's very non-specific. We could see a yolk sac in the adnexia, or if we're very lucky to reach a fast and quick diagnosis, we could see fetal pulse or heart activity in the adnexia. So either one of those will be evident on ultrasound. Unfortunately, usually all we see is the first, an empty uterus, and we see nothing else. Okay? Just a moment, I'm gonna share something else with you guys. Come on, Teams. Okay. Stop sharing. ليش علقة؟ مش مشكلة. اوكي، شايفين السلايدز ولا لا؟ السلايدز واضحة؟ شايفين. اوكي. ثاني في مشكلة حتى بالسلايد في overlap. Okay, there we go again. Okay. So usually that's all we see on ultrasound. That's the thin endometrial stripe. That's the uterus. That's the myometrium. The pouch of Douglas is here. And if the bladder was full, you'll see it somewhere around here. Okay, and that's an empty uterus. Unfortunately, that's usually what happens. Now, in general, what we need to understand about beta ECG, that's beta ECG over the first 40 days after implantation, after ovulation, sorry. So you see that beta HCG rises slowly. In general, beta HCG rises in viable pregnancies around 60% every other day. And that has an impact on how we utilize it later on. Sorry. Okay. Here you'll see the luckiest case scenario, or not for the patient, but for us as physicians. So that's the ultrasound. That's the uterus, sorry. This is the cervix. This is the endometrium. That's the right ovary. What do we see here? Is the image clear?
You'll say, kind of. Oh.
Actually, this is the ovary. This is the tube. And what do you see within the tube?
The embryo or a sac.
Yeah. Yeah, that's the embryo with fetal heart motion. If you focus on my circle, let's just delete everything. If you focus here, the heart is beating. Another unrelated question. Do you see this structure that is moving? Is it clear for everyone? Okay, what do you think this structure is? If you know your anatomy, you'll know the structure. This is the ovary. This is the uterus. You have a hypoechoic structure that is moving on its own. Any guesses? Okay, do you guys know what black means on ultrasound?
Fallopian tube?
No, black in general on ultrasound. What does it mean?
Air.
Actually, air is not visualized on ultrasound. It means it's fluid. So there is a fluid containing structure going just beneath the ovary. What is this structure usually?
The bladder?
No, the bladder is anterior. If the bladder was full, you'll see it somewhere around here.
Blood vessel?
Yeah, it's a blood vessel. Which blood vessels pass just beneath the ovary?
Lower than the bifurcation.
These are the internal iliac vessels. That's the vein, and the smaller structure just behind it, that's the artery. The vein is moving by effect of the artery beneath it, actually. And that's one of the ways we can reach or visualize the ovary. We look for the internal iliac vessels. If you look also somewhere around here, what area is it? This area I'm shading right now. Any guesses?
Adnexia?
No, it's not adnexia. Afwan? Usama?
Kidney?
No, the kidney is way high for you to visualize while visualizing the uterus. You'll never visualize the an empty uterus and a kidney in the same plane. The kidney is almost at the level of the liver, correct? And here we're talking about pelvic organs. So that's the patch of Douglas. Okay, and if you see, there's some hypoechoic shadows here. That's fluid in the patch of Douglas, and actually, this hyperechoic lesion here, that's a clot. Because clots are solid, they appear white, while fresh blood is fluid, it appears black. So this is all blood, and this is a well-formed clot. That means this lady has been bleeding for a while due to her ectopic pregnancy. So let's go back to our case. Now, usually in your exam, you'll not be presented a case in advanced gestation in regards to ectopic pregnancy. So let's presume you have a lady, the same presentation as your colleague alluded to before, and she has vaginal bleeding and abdominal pain, and you see an empty uterus. You do a beta ECG. The beta ECG is 300. Okay, what should we do next? What should be our next step in this lady?
Waiting, دكتور.
يعني, what do you wait and do? How often would you see her?
بدي أشوفها يمكن مش متأكد، بس لمن لسه مش مبين الساك ما راح يبين هلا، يعني ممكن يكون عادي، يعني لسه في pregnancy.
Okay, so our first step is to know that it's normal that we did not observe an intrauterine pregnancy because it's just below the discriminatory zone that we discussed before. And that's the purpose of the discriminatory zone. So you wait, you tell her it's expected that we did not observe an intrauterine pregnancy because the pregnancy seems to be still early on. And what do you do next?
We do the laparoscopy.
No, we don't go for laparoscopy. Fahad?
يعني I will repeat the test after 48 hours وممكن أعمل transvaginal ultrasound.
طيب. You repeat the test in 48 hours along with the ultrasound. The initial result was 300, correct? The next result was 550. What does it mean? You still I wouldn't expect you to visualize anything on ultrasound because it's still below the discriminatory zone.
It's mostly ectopic pregnancy.
If it's 550, it's ectopic pregnancy.
Yes.
Okay. Hassan, do you have any other suggestions? Or Hassan this time? Any other suggestions?
مين دكتور؟
حسن يوسف جبر مش حسن.
نو دكتور.
لأنه رافع إيده. تفضل.
نو دكتور. كنت رافع إيدي من قبل.
أوكي.
يس دكتور، أنا هلا إذا في مجال.
تفضل.
دكتور إذا 560 I just wait كمان لأن في doubling يعني.
Okay. Does anyone? I got your answer. So does anyone else have any other suggestions? I'm not saying any of you are right or wrong. I'm just accepting answers for us to discuss the right and the wrong ones. So let me go back a couple of slides. Come on. That's how we manage this case. So I have a lady, we suspect her that she might have an ectopic pregnancy. We have three results. Either we do an ultrasound and we can confirm that there is an intrauterine pregnancy, the lady is safe and square, we reassure her, and we send her home on her way. Or, which is the most common situation that actually occurs, we can observe nothing on ultrasound. And that's our dilemma in most cases. Or we'll see an ectopic pregnancy and we confirm the diagnosis. That might occur. So let's go with our scenario in the middle. We do a beta ECG. We said that the beta ECG was 300. So it's below the discriminatory zone. If it's below the discriminatory zone, we should repeat it in 48 hours. The normal rise of a viable pregnancy in 48 hours is around 63%. Okay, what that means is that if a lady's beta ECG level increases by more than 63% in 48 hours, she has a 96% chance of this pregnancy being in utero and a viable pregnancy. So if that happens, we reassure her. We tell her that this is most likely an intrauterine pregnancy, although we can't 100% confirm it yet. And we tell her if she doesn't have significant abdominal pain or vaginal bleeding, we'll see her again in a week. By 1 week, we expect the beta ECG to be more than the discriminatory zone, and if it's actually an intrauterine pregnancy, it should be visualized. Okay, but not increased by the 63%. Let's presume it was 300. Right now is 380. What does 380 mean in this case? $380 in this case means that this is most Afwan?
Less than 15% increase.
أنا هون كان المفروض أكتب drop. فهي مش less than 15, you know, it increased but less than 50%. So that what happens. If it increased less than 50%, it means most likely it's an ectopic pregnancy, and we treat it accordingly as an ectopic pregnancy, depending on certain criteria we should meet. On the other hand, if it either, let's say, dropped slightly, it's 280. This means this is a failing pregnancy, and we just ask the lady to repeat her beta HCG in 1 week or 2 weeks to confirm that the beta HCG dropped to 0, and we do nothing. So these are the 3 most common scenarios we might encounter. Usually during your exam, either the first or the last will be presented to you. So let's go with each one of those. So your patient, you repeated her beta HCG, it was 400 and it increased by less than 50%. Then you do an ultrasound. On the ultrasound, you see no intrauterine pregnancy, no extrauterine pregnancy, no free fluid, and no adnexal masses. She's vitally stable. How would you manage her? What should we do next?
دكتور ايش كان الانيشال بيتا اس جي وايش صار؟
Regardless of the initial beta HCG, the beta HCG it's below 300, it's below 1000, below the discriminatory zone. We don't see an extra. We did doubling, and the doubling was less than 50%. We did an ultrasound after the beta HCG. We have no intra or extrauterine pregnancy and no collection of fluid in the pouch of Douglas.
دكتور ممكن أفكر في إنه صار معها miscarriage يعني.
We already said that less than 50% does not mean a miscarriage.
Okay, ممكن يعني pregnancy of unknown origin يعني غير الإكتوبيك.
So what should you do next? Okay, let's return to our general concepts for a moment. I'm just gonna discard. Just give me a moment. I'm gonna close this. I'm gonna share my whiteboard again. Okay, كل شايف البلاك بورد؟ Okay. So let's presume you confirmed. الكمبيوتر بلش يحمى. You confirmed she's carrying an ectopic pregnancy. So you repeated the beta HCG. It increased by less than 50%. What should you do next? What are her options, this lady, to be treated? in general, we have three options. Medical and surgical. And you have to know the criteria that every lady should meet for each type of these managements. If she's a candidate for expectant management, what should the criteria be? Or what criteria should she meet to be a candidate for this type of management? Amr? So HCG less than 1000 and falling. شو كمان؟ بغششكم أول تنتين.
دكتور
تفضل.
دكتور أول شيء تكون hemodynamically stable البيشنت وما في symptoms عندها.
So no abdominal pain. Hemodynamically stable. شو كمان؟ The sac should be less than 3.5 centimeters and no fetal heart. Yes, no fetal heart activity. So if she meets these, she's a candidate for expectant management. What we mean by expectant management, we explain to her all her risk. Of course, she should be a reliable patient that could seek medical assistance whenever possible. Yeah, we don't send a lady with no access to medical services for expectant management, because if the worst occurs, she'll come back to us dead. In expectant management, we see her in a week, and around 70% of these patients will have successful expectant management with doing nothing, just observation. طيب, what will make her a candidate for medical management? حسن؟
يس دكتور. دكتور أول شيء إنها تكون أقل من 3.5 سنتيمتر الساك.
أوكي.
إنه ما نشوف fetal heart كمان.
Okay, I agree.
Yes.
ايش الثاني بتحب تزيده؟
Yes, if you allow me. البيتا HCG يكون مثلا أقل من 5000.
اوكي، راح تلاقوا البيتا HCG هاي راح تغلبكم شوي، في ناس راح يحكوا لكم 5000، في ناس راح يحكوا لكم 6500، كتابكم إذا متذكر صح كاتب 6500. Okay. In general, the higher the beta HCG level, the higher risk of failure. شو كمان؟ فيليب؟
انه ما يكونش في فيتال هارت بيت، وبرضه ما يكونش في عندنا intrauterine pregnancy مع الاكتوبيك.
اوكي، شو كمان؟ اهم
برضه البيتا HCG يكون 10000 او اقل.
حكينا البيت HCG نمبر، وحكينا انه راح تلاقوه اكثر من رقم، بس بالعاده راح تلاقوا بين ال 5000 و 6500. Okay, she should be hemodynamically stable. That's the main issue here. Again, she should be hemodynamically stable. What do we mean by medical management?
Methotrexate, doctor.
So, medical management معناته Methotrexate. معظم الأحيان احنا بنختصر Methotrexate نكتب MTX. Okay? So, Methotrexate. What's Methotrexate in the first place? سهى أو شهى عفوا مش عارف
دكتور.
عفوا شو الاسم؟ شعاع، آسف.
لا بسيطة. Methotrexate folic acid antagonist، يعني it should stop dividing trophoblastic cells.
So Methotrexate is a methylene tetrahydrofolate reductase enzyme inhibitor. This enzyme is responsible for converting folic acid to the active form, which is called it's called methylene tetrahydrofolate. That's how this drug works. So it converts the inactive form that you absorb from your nutrition to the active form. What you also should know about methotrexate are contraindications. What are the contraindications for using methotrexate? Philip?
Abnormal liver function test or kidney function test.
Okay, so liver or renal failure. Correct. Why liver? Because this drug is metabolized by the liver and excreted by the kidney. So if you have problems with the kidney, well, you'll have toxic doses because you can't excrete it. And if you have liver failure, you'll be unable to metabolize it. And again, you'll have toxic doses other than liver and kidney failure. Anaphylaxis or any sensitivity. Any other?
Active infectious diseases دكتور.
اوكي غيره اهم منه.
So immune deficient.
حكاها فيليب Ectopic pregnancy.
مش سامع.
اللي حكاها فيليب Ectopic pregnancy.
Okay. Any viable existing intrauterine pregnancy. شو كمان؟
دكتور ممكن breastfeeding.
Breastfeeding, of course, but that's for in general for methotrexate. Here we're talking about methotrexate in ectopic pregnancies.
ممكن تيجي عنا دكتور انه delivered recently وصار عندها حمل يعني بعدين يعني ممكن بهاي السيناريو.
كيف يعني؟ ما فهمتش.
يعني تكون already هي breastfeeding a baby وصارت pregnant.
If she gets pregnant, she'll stop breastfeeding anyhow. Okay, so breastfeeding is indeed a contraindication. But it's more important, any bleeding diatheses, any bone marrow disease, such as MDS, lung fibrosis, and so on. These are all contraindications for methotrexate. So what we actually do is that we give her methotrexate, the dose which she should not remember as students is 50 milligram per meter square. See, we calculate the surface area. Most female surface area is around 1.7. So most females receive around 80 milligrams. We give her the dose. And then at day 4, after giving the dose, we do beta HCG to confirm that beta HCG is dropping. And we repeat it again at day 7 to confirm that beta HCG is again dropping. If it does not drop, yani we're failing medical treatment. So if the lady does not meet medical criteria or criteria for medical treatment, we should go for what type of treatment?
Surgical, doctor.
So go for surgical. What do we mean by surgical treatment? What are our surgical options? In other words, what are our surgical options for managing ectopic pregnancies? Okay, if she's hemodynamically stable, we go for laparotomy. Now remember, when you describe a surgery, there are two issues you should describe. One is the approach. Two is the technique. هذا قرر. طيب. sorry tablet كله علق. Okay, مش مشكلة. So you have the approach and the technique. By technique, we mean that, for instance, I'll discuss it later on. For approach, we mean it's either laparotomy, vaginal, endoscopic, laparoscopic, and so on. And then we have the technique, which is the actual surgeries we're going to perform. So let's say, Hamza, what would you suggest as surgical management of ectopic pregnancy?
دكتور البريفيرد بيكون لاباروسكوبي. التكنيك او الجو يعني في عنا تو تشويسز، يا اما سالبينجوستومي او سالبينجكتومي حسب اذا في عندي التيوب رابتشرد ولا لا.
Tube rupture is not actually one of the more important parts. Amr, do you have any other suggestions or anything else to add to our topic? Or Rowan? So in regards to surgical management, unless the patient is not hemodynamically stable, we go for laparoscopy. In laparoscopy, we have three solutions. One, and the ideal one, is salpingectomy. Salpingo means tubal, ectomy, removal. So you just excise the tubes. Or we can go for salpingotomy. By salpingotomy, we mean that we open the tube, we remove the tissue, and we close the tube. Or salpingostomy. And in salpingostomy, we mean that we open the tube, we remove the tissue, and we keep the tube open. How do we choose whether to go for ectomy or salpingostomy and salpingotomy? Well, the ideal treatment is salpingectomy, as I said before, because if ectopic pregnancy has happened, that means most likely this tube is diseased and there is high risk of recurrence in the same tube. But you observe both tubes. If one of them is diseased, then we have to preserve the other one, and we'll go for salpingotomy and salpingectomy. Otherwise, it's always ectomy and removal of the tube. So these are our surgical options for managing an ectopic pregnancy. Okay, always try to remove the tube unless you have another diseased tube. When do we go for surgery? One of two solutions. Either they failed medical treatment, or they have a contraindication for medical treatment, or they do not meet the criteria for medical treatment. We go for surgical management of ectopic pregnancies. Okay? So any questions so far about ectopics? Do you guys hear me?
Yes, doctor.
Yeah, because I can't control the screen anymore. Something happened. Just give me a moment. So as a summary, ectopic pregnancy is when an embryo implanted anywhere about within the endometrial cavity. The most common type of ectopic pregnancies are tubal ectopics, and these are the ones you will face as medical students usually in the exam. Okay, the most common site within the tube is the ampulla of the tube. They usually present with first trimester bleeding associated with abdominal pain after a period of amenorrhea. Our first steps is to ensure that her hemoglobin is normal, so we do a CBC, an ultrasound, and a beta ECG. If the beta ECG is above the discriminatory zone, which is usually between 1200 and 1500, depending on your reference, and we do not observe an intrauterine pregnancy, then we'll go for doubling of beta ECG. In other words, we rate the beta ECG in 48 hours. The normal rise in normal pregnancies of beta ECG is 63% in 48 hours. So if it increases more than 63%, most likely this is a viable pregnancy. We reassure our patient and see them again in a week. If it's less, it's either a miscarriage or an ectopic. If it's less and we suspect it's an ectopic, we have three solutions. These solutions depend on the hemodynamic status of the patient, the size of the ectopic, if it's visible on the last ultrasound, and the beta HCG, absolute beta HCG level, the last beta HCG level. Expectant management is when we do nothing and we just observe the patient in a week, and it's successful in around 70% of cases. The patient has to be stable. There should be no fetal heart activity. The beta HCG should be less than 1,000 and or 1,500 and dropping. And the patient should have access to medical services. If she doesn't meet these criteria, we go for medical treatment. By medical treatment, we mean giving her methotrexate. Methotrexate is a chemotherapeutic drug. It reduces the bioavailability of the activated type of folic acid, and it's contraindicated in liver failure and renal failure, and patients with allergies, and currently pregnant and or breastfeeding women, and patients with bone marrow failure and pulmonary fibrosis. The indications for medical treatment is that the sac should be less than 3.5 centimeters with no fetal heart. The beta HCG is less than 6,500, and the rest are the same as expectant management. If she does not meet these criteria, we have the last solution, which is the surgical management, which is usually done via laparoscopic approach unless the patient is hemodynamically unstable. In laparoscopic approach, the ideal treatment is salpingectomy, which is removal of the diseased tube with its included pregnancy. If salpingectomy fails, or if salpingectomy is not indicated, such as in patients where their contralateral tubes are diseased, then we go for either salpingotomy, during which we open the tube, we milk its contents, and we close it again, or salpingostomy, during which we open the tube, we milk its contents, and we leave it open, creating a stoma. In general, whenever a patient undergoes salpingectomy or salpingectomy, there is another precaution we should take, during which we repeat beta HCG 1 week after the surgery, because we're concerned that there might occur something we call persistent trophoblastic disease. So we should confirm that beta HCG returns to negative. So that's a summary overall of ectopic pregnancies. The most difficult principle for you guys usually is the beta HCG doubling and how to manage beta HCG doubling. But otherwise, it's supposed to be a straightforward subject, and you should try to study it along with all causes of first trimester bleeding, such as miscarriages and molar pregnancies. Any questions from anyone, any of you guys?
Yes, Doctor.
Go ahead.
Doctor, I have two questions. The first one, and قرأت إنه في rare cases بصير عندهم what they call heterotopic pregnancy، إنه بيكون في pregnancy بالuterus و ectopic pregnancy.
Yes.
يعني how do we manage this case if this baby is a precious baby? Second question is يعني what's the goal behind salpingostomy؟ يعني كل الريفرنسز حكوا على salpingectomy وsalpingotomy، فايش الجول من salpingostomy؟
Okay. Now, the general rate of ectopic pregnancy overall is around 1 to 2%. Heterotopic pregnancy is 1 in 30,000. So it's 0.003%. Okay, so it's quite rare. You as general GPs in the future are not expected to be able to recognize or treat heterotopic pregnancies. In general, heterotopic pregnancies are treated surgically by removing the ectopic and keeping the intrauterine pregnancy. That's why we don't use medical treatment with coexisting pregnancy, because we'll kill both if we do medical treatment. So you just remove the ectopic surgically, and the intrauterine pregnancy, you keep it. Now, in regards to salpingotomy and salpingostomy are the same, and they're indicated in the same situations. Okay, there is almost no therapeutic difference between both. It's just preference of surgeons and how they were taught. All you need to know is that the ideal treatment is salpingectomy, not salpingostomy nor salpingotomy. Okay, is it clear?
Yes, understood. Thank you.
Okay. Any other questions? Because we already took 1 hour and 15 minutes, and I know that you guys, after the first 40 minutes, are mostly absent-minded. So I don't like to take longer sessions. Okay. I hope you guys all the best. Please remember that you're required reading textbooks are Hacker and Moore's Essentials of Obstetrics and Gynecology, and Obstetrics and Gynecology by 10 Teachers. The subject of today, you'll find it mainly in Gynecology by 10 Teachers. Okay, and remember that ectopic pregnancies, even if you're not an obstetrician or a gynecologist, are one of the very common pitfalls that ER doctors and surgeons fall for. Because sometimes they just present with abdominal pain and they forget to ask about the amenorrhea or the vaginal bleeding, and they forget to establish the diagnosis early on. And no lady should die from an ectopic pregnancy in this day and age. We have easy access to ultrasound, and beta HCG is easily done. A urine beta HCG kit is very cheap, and it does not even need a lab to establish that, at least to know that the lady is pregnant. And have a good rest of your days. Bye. الله يعافيك.
دكتور يعطيك العافية.
الله يعافيك.
يعطيك العافية.